name is Austin Bradley, and this presentation is going to be about the facility that I am a director of nursing at, Merced Behavioral Center. And the focus of our presentation today is going to be continuous improvements in the psychiatric facility setting. So today's presentation, broken it down to 5 different categories. The first one we're going to take a look at our SWOT analysis and goals, because we want to see where our strengths are and where our weaknesses are, our opportunities and our threats, to assess what direction we need to go. And then we're going to look at our strategy map, just a quick look to see how effective our plans are in tackling what our goals are. And then we're going to look at our action plan, the actual ways that we are going to tackle on these problems and come up with solutions. We'll also talk about our communication plan and how we intend to disseminate that information to the stakeholders. And lastly, we're going to be looking at our evaluation piece so that we know that we are going in the right direction, and if there's any changes that we need to make, we can make them at that point. So let us start with the SWOT analysis and goals. So a SWOT, just to be very brief, we're not going to go into detail on this, but just to get an idea of why we're doing this. A SWOT is our strengths, weaknesses, our opportunities, and our threats. So looking at these 4 different areas, we want to assess what we have and where we need to go. So let's look at strengths first. First off, with my facility, we have really strong compassion. We actually have individuals who want to work at our facility, not for the check, but for the residents. With our residents, they have a high degree of falling through the cracks. I firmly believe they're the second most at-risk population, secondary to premature babies, because they're adults. They're adults, however, they lack the capacity due to the mental illness to be functioning adults in society. So people look at them one way, but they think another. We have staff that understand that from the interview day. They're drilled into it that this is their home and we're the visitors, and to treat them with dignity and respect. So we're talking about compassion. We have a centralized location. Merced Behavioral Center is smack dab in the middle of California, and we serve all California counties. And we are also very data driven, with Merced Behavioral Center focusing on a QAPI, which we'll get into, a QAPI sort of mentality. We're looking at real, effective, and sustainable change. It's QAPI, it's QAPI, and again, we will get to that later on in the presentation. We are employee friendly. Staff morale is not a buzzword. It is actually one of our priorities. We firmly believe that if you treat, to paraphrase a quote from Richard Branson, we firmly believe that if you treat your employees well, they're going to treat their customers well. Well, our customers are the mentally ill patients that live in our facility day in and day out. So we want us to treat our employees well so that they can treat our customers, in this case the mentally ill residents of our facility, well as well. We're also have very few direct competitors. Direct meaning the Institute for the Mentally Disabled, IMDs. There are very few in California. They've decreased in number and also been ate up by a single entity known as Crestwood. A lot of them have been purchased by this company. We're one of the few that isn't part of Crestwood. We are, however, part of an entity known as Cambridge, which has 3 psych facilities. 3 IMDs. We're one of those 3. But we don't really directly compete with one another because geographically speaking, we're so sparse that it's not really an issue when it comes to eating up the same type of clientele at the moment, however. In education connection, we have a strong connection with our local colleges here at Merced, and also outside of Merced. We have a connection with Merced College with their CNA, LVN, and RN program. Those are nursing programs. And we have a connection with Gurnick Academy, which is in Fresno, California. They will be doing their rotation in our facility to help promote psychiatric nursing as an option for these nurses who are coming out of school. Weaknesses. Community investment, regional area is really unaware of our presence, so we really don't have much to do with the community, which we are hoping to focus on. Outdated technology, have your papers and pens ready, because our facility is unfortunately still not fully electronic, as most psychiatric and most hospitals are. We are in the process of that transformation, but it requires a change in our infrastructure regarding the cables and the bandwidth of our facility. We're not prepared for it yet. We are going to be down the line. Cambridge, our parent company, is looking into that. Eagerly, we are waiting for that. And also, poor visual milieu. Welcome to Merced Behavioral Center, serving California since 1973, and it looks like it too. I came on board last year, and one of the things I noticed is how outdated the facility looks, how aged it has not done well. So we are already looking into that as well when we assess our weaknesses. Also, limited space. We have fixed amount of beds, 96 beds. We don't have any more space than 96 beds. So that means we also have a fixed revenue stream. So in order to increase our revenue and our net profit, we need to decrease our spending, which is a double-edged sword. Opportunities, better community reintegration, true focus on reintegration of the community after treatment, and better public relations. Does anyone really exist without a website? We don't even have a website now. We have one in the process of being made. It is already completed. It just has not gone live yet. It's in the final process of being approved. And also updating our look, bringing MBC, Merced Behavioral Center, to the post-Facebook era. Social media is a huge stepping stone for a lot of businesses, and I know we're psychiatric and a lot of our patients have to undergo a legal issue, but if we catch them early, at least we know, let them know of our presence, and unfortunately something happens to them down the line, they might think back, oh, I remember looking on Facebook, or I remember looking on Twitter about Merced Behavioral Center, and let me talk to my conservator about possibly doing my treatment there. And our threats, we have one, augmented boarding cares. Note that it was not other IMDs. Like I said as before, we have very few direct competitors, but augmented boarding cares are cropping up all over California, and they're closer to the community. They're more tight-knit to communities. They're not locked facilities. They don't have a big fence. They don't have locked doors and everything like that. It's rather open. It's for clients who are wanting to work a treatment program, but don't need the restrictive environment of an IMD. Because they have a pretty effective treatment, and they're closer to the community, don't require being a locked facility, and they don't have around-the-clock nursing care like an IMD has to have due to Title 22 regulations, they are far cheaper a treatment program than what we can provide. So that is a threat. We have to justify our high costs. We cannot cut our costs because we are already running at the margins when it comes to our nursing care, and like I said, we cannot increase our revenue stream because we cannot add beds to our facility. So that's our SWOTs. Now let's look at the strategy map. To understand the strategy map, we have to look at the mission statement and the goals. So Cambridge mission statement is our mission is to be the premier provider and employer by always doing the right things. That is their mission statement. Our goal over at Merced Behavioral Center, due to the threat of the augmented boarding cares, is to justify the cost by increasing the knowledge of the differentiation between ABCs, which is augmented boarding cares, with our IMD, and increase the change for treatment success while improving the lives of both our residents and the satisfaction of our staff. A pretty big goal, but basically in a nutshell, we want to improve the lives of our staff, of our residents, of their satisfaction with our facility and the program, whether they're in the program or whether they're an employee of our facility. And by doing so, we want to increase the chances of them succeeding out in the community. We want to reduce our recidivism rate. So here's our strategy map. It's a bit convoluted, but let me just break it down to a nutshell. Project Mentor is one of our major focuses right now this year. It is a focus on special treatment program. It is a QAPI. Again, we'll get to what a QAPI is in a minute. As you can see from that blinking, that is how much Project Mentor encompasses of this strategy map. The other project that we have is called Cafe Salveo. Salveo meaning wellness. It's Latin for wellness. Focus on resident dining experience. Dining and eating in general is such a major portion of our lives. Outside of a locked facility, you can't imagine how much that has been exponentially increased when you're in a locked facility and don't have much to do. So we want to focus on that. And then again, that's how much of it is encompassed by that. And then the last thing that we're focusing on is going to be staff morale committee. A focus on staff morale and satisfaction. And that's how much of the strategy map is affected by that. Our action plan. So I've been mentioning QAPI, but let me tell you right now what QAPI is. The Q in QAPI stands for quality. We want to focus on the quality of our care to our residents and, by extension, to our staff. With the assurance, A stands for the insurance, backed by data. It's data driven. P stands for the performance, to improve the performance of Merced Behavioral Center, and I is for improvement with continuous improvement, continuous, it doesn't end. So the action we take, we want to assess the current situation. We want to compare the facility vision and goals to what we have currently. How far are we from our mark? We want to survey both residents and staff. We want to give both sides of the coin as to how the facility is going in those three different categories. And last is to strategize. We want to strategize through an interdisciplinary approach in a QAPI data-driven format. A QAPI committee is interdisciplinary. It has members from employees from nursing, from our program, which is our special treatment program department. We have individuals from our dietary department. We have individuals from our housekeeping department, from our maintenance department, from our social services, from our activities. It is interdisciplinary, and it's not just heads, it's not just management, it is the floor staff as well, getting a very round and diverse look into our facility. So all four of those combined is how we are going to tackle on these changes. So the three QAPIs, the first one is Project Mentor. As I mentioned, it's a focus on the community reintegration, reintegrating these individuals, and our residents are between the ages of 18 to 65. They're at the prime of their life, with the average of them being between the ages of 35 to 45. Focus on community reintegration. We want them to go back into the community and back living their lives. We want to reduce the recidivism rate. Recidivism is the cycle of coming in and out of our facility, coming in and out of psychiatric hospitalizations period. We want to actually measure, document, and improve those numbers. And we want to decrease premature discharges. We really want the counties to understand that if we don't feel that they're ready for discharge, they have to really listen to us, because we're not going to force them. Of course, it's up to them. But we want to back it up with data saying, look what happens when you prematurely discharge them. This is the data that shows of their increased chances of being hospitalized from the data that we've collected. Here is the data if we continue to keep them for the month that we feel like they need, or the 2 months that we need. On average, our residents stay at our facility for 6 to 9 months. It used to be 3 to 6, but that shows you how difficult mental illness has been recently, especially with the emergence of a lot of different drugs out there and a lot of different stimuli with social media and screens all over the place, and the lack of familial support that's going on. It takes a lot longer for them to rehabilitate. This is going to be done by the management by objectives and management by means method. Management by objectives is because we're going to have goals, set goals, defined, smart, measurable goals. And management by means, we're going to talk about why. We're going to focus on the why we want these goals. And it is what I just said, it's because we really want them to be reintegrated back into community. We want them to live their lives. We want them to be back to their families. They can be productive members of society. If only someone can tell to them, you can be productive members of society. You're not vagabonds. You're not tossed out by the system. Cafe Salveo is another one. Is another program that we have. With Cafe Salveo, we want an updated look of the dining room. The dining room looks old. It looks like a mess hall in a prison. We want to update it. Round tables, tablecloths, all that stuff. We want to update the process of dining. Stop yelling out their names and start saying, table 2, your table's ready. Table 5, your table's ready. Cart 6, your trays are ready. Something along those lines. And we also wanted to increase the milieu of it, make it more therapeutic, home-like. Maybe have some ambient music. Maybe have, we really want to focus on conversation. Have our staff sit down with them and have a conversation with them, just like you would at a family dining table. This will be done by the management by objectives. We're going to have objectives. We're going to have goals that we're going to meet. And some of those objectives will be satisfaction numbers that we're looking at. And it's going to be a single-use plan. We're hoping to have a one-and-done type of aspect to it. Really, really bring the dining room up to date and be done with it. Of course, maybe review it later in the future, but because of the extreme cost it's going to take to get new tables, new dining cloths, new decor, painted walls, and everything like that, that's something we kind of want to give one shot in and done. And then the staff morale committee. We want to monitor staff satisfaction. We also want to inspire staff to make these positive changes. We want them to feel like they're a part of it. We want to engage with them. We want them to be engaged with our facility. We also want to decrease the avoidable losses from turnover rates. As I said before, we can't increase our revenue stream by increasing the census and the bed count. All the finances are pretty fixed. We give counties a fixed rate. There's no Medicare, Medi-Cal. We say this is how much it is per night. This is how long we anticipate them staying. This is how long they stayed. Here's the bill. Pay it. So we're constantly full. That would be something that facilities would focus on, is to make sure our census is full. But because of the dynamic of mental illness, we are always full. It's not a problem for us. So we have to decrease our costs, and our cost can be decreased by the avoidable loss from turnover rates. It costs from $3,000 to $10,000 per employee loss and more. We want to keep it as low as possible and only have a turnover rate if they're necessary. This is going to be done by management by objectives. We're going to have goals for the staff morale committee, staff satisfaction numbers. We're going to also have goals as to how many dress down days we're going to have, how many beds we're going to have per season, per month, etc. And we're going to have standing plans. This is going to be done on an ongoing basis. It's not going to change because staff morale is always going to be at the top of our heads when it comes to how we want to treat our facility. Communication plan. So we have to understand what the stakeholders are, who the stakeholders are in our facility. There's a lot of them, but let's just talk about 4, okay? Residents, our residents, current or prospective residents, and then their families. Now, families are not necessarily involved. They're legally bound to be in our facility, and it's usually their conservators, which are legal representatives that are engaged in their treatment. But if family wants to be involved, we want to get them involved, because to reduce that recidivism rate, we need to make sure they have a strong support system. To make sure they have a strong support system, if they have their family involved, we want to get the family involved. We want to educate the family as long as HIPAA allows it, as long as there's a release of information from their county. So there's families. Staff, we want all departments to be addressed in these changes. We don't want to leave anyone behind. From dietary to activities to housekeeping to program to nursing, we want everyone involved. The county agencies, these are conservators' offices. These are the ones that pay the bill. But also keep in mind, they're the ones that has the least amount of effort involved with the program. So let us get them more involved. Let them get them to understand what we do in our facility and why you should trust us when we say your client is not ready to go yet. And we're going to have data to back it up. We're not going to keep people longer than they need to be there. We want them to move on. We have plenty of packets. We have plenty of residents who want to be in our facility. That is not a problem, as you can tell from our full census constantly. We're running always at 98, 99% around the year. But we want them to understand, to trust us, so we can avoid those losses, because it's been a trend lately where county wants to save money, so they send their clients to a boarding care, or to an augmented boarding care. They pull them out, even though we don't recommend for them to be pulled out. They go to a boarding care, they fail, they either get into drugs, or they decompensate, or what have you, and then they come back to our facility and we're back to ground zero. Lost time. They could have had those months. They've been with us for 3 months. They could have just 3 months more, they would have been done. You know, time is precious, especially with mental illness. You have a lot of comorbidities. You don't have a lot of time. A lot of our residents, they don't die in old age. They die earlier because of the pancreatitis or the metabolic syndrome that occurs because of this, because of their psych meds, or because of their poor eating habits, or because of the drugs. So we want to focus on that. And then the regulatory agencies, CDPH, the California Department of Public Health, Department of Mental Health, the Ombudsman, Patients' Rights. We want them to be aware of the changes that we're going to do. So how are we going to let them be aware? Well, let's start off with the residents. How are we going to make the residents be aware? So everything starts with the QAPI. All changes occur through that because it's a well-tuned process that's data-driven. It has the assurance of the data. We want to increase the performance through QAPI. So here are 4 methods in which we can help disseminate the information. FL stands for flyers to the residents. TM stands for the teams. Now each resident is part of a team. There are 4 teams, but they also have team meetings. They have a team leader that can help disseminate this information. RG stands for resident government, which is like a town hall setting that they have, that they can have discussion back and forth. And they also have representatives from their teams to management. And then SU stands for surveys. It's the survey process that we have so we can get that feedback back and forth between them. As you can see, there's two different colors. The blue ones, the blue circles, that indicates a formal form of communication, whereas the gray stance is more of, can be informal because that back and forth, that ebb and flow of communication from management to the floor, to the residents, or vice versa. So we're tackling on two different ways of communicating with them. So that's how we're going to address the residents. ST stands for staff, how QAPI will inform the staff. MM stands for the monthly meetings that we have, the meetings that we sit down and we talk. We sometimes have all CNA meetings, sometimes I have an all nurses meeting. Also, MM is also like memos as well from those meetings that we push out there to the staff lounge, to the nurses station, so that they can get information. Unfortunately, we're not fully electronic yet. With point-click care, which is the electronic medical records that we're planning on going to, has a way of disseminating that information, but right now we don't have it. We're still paper and pen. MT, again, stands for the meetings that we have. SU, right here, is the surveys. We do have surveys. And AS is the all-staff meeting. We have an all-staff meeting every month where staff is invited to our lounge. We have food, and we also discuss. We announce and we discuss. We announce our employee of the month at this meeting, among other things. And it can be a lively discussion. Again, the blues are the formal ways that we communicate, and the grays can be informal because of that ebb and flow. More traditional informal communications, the gossip, the clusters. We also can have that with staff. Gossip is something that we actually try to eliminate, hence why we try to make sure we have enough formal ways of communication that's initiated by management to them. But the cluster way is also a really good way that we communicate. We have leads on each shift. We disseminate that information to the leads. We have leads meetings, and those leads then disseminate the information to the floor staff. That way it's kind of a one-stop shop when it comes to communication, so that there's reduced risk and miscommunication and noise. County agencies, we fax them quite often. That's what the FX stands for. Again, MT meetings, sometimes we have meetings with them. We have phone conferences with them, and that can have an ebb and flow of communication. Surveys, we can also do surveys with them as well. We plan on having surveys once we've done all of our changes to ask them how they feel about all the changes that we made. And then WS, website. We want to make sure that we have a website, not necessarily for the residents or prospective residents, but for the counties too, because when the counties are trying to convince to have the least amount of resistance, hey, why don't you go to this treatment facility, they can at least have something visual to show them. Because right now they got nothing. We have nothing other than a reputation, which has been increasing in prosperity and satisfaction in the past year since I've been director, I'm happy to say. Because it's been a focus, right? Before it wasn't a focus, not necessarily me, but now that it's a focus, it's getting good. And then RA, regulatory agencies. One thing you want to notice at first is that none of these are great. We don't want informal ways of communicating with these regulatory agencies because we don't want to have any miscommunication. We definitely want it to be formal. So we fax them any type of changes that we make, any type of instances that occur. PP stands for, SS stands for state surveys. So we also have state surveys, and then we also have follow-ups. When they follow up with complaints that can occur, they come to our facility. So last thing, the PP stands for actually policy and procedures. Anytime we have a change of policy and procedures, we have to alert them, whether it's nursing related, so we alert the California Department of Public Health, or if it's the special treatment program related, which we alert the Department of Mental Health. Evaluation. So, how do we know what we did was right? We want to collect data. Staff from all departments, we're going to be asking them voluntarily to submit data. These voluntarily submitted data will be done anonymously through SurveyMonkey. What I did was, which because I've already been doing it, is I have a QR code. Now, cell phones are not allowed on the floor, but the QR codes are in non-resident areas, so they can just hover. I have directions on it on how to hover over the QR code, and it'll automatically pop up the website. You click on it, and then you can submit your data. There'll be a time limit on the survey window. I'm not looking for a number, but I'm looking at, hey, you have 1 week to submit your ideas or your data. It can be done on personal devices or on a facility iPad. We can help them do it if they request it. Residents from all teams, there's 4 teams total. We're going to do a random sample of 10 residents. This is 10 residents out of 96, roughly about 10% of the residents. We want them to be representative of the 5 levels of functioning. They go from level 5, 4, 3, 2, 1, 1 being the highest functioning, 5 being the lowest functioning. Half of our residents, almost half of them, are on level 5. Then we have, get smaller and smaller. So we want 4 of them from level 5, 2 of them from level 4, 2 of them from level 3, 1 from level 2, and then 1 from level 1. Unfortunately, I think we only have like 1 or 2 people who are on level 1. It's usually because the county pulls them out by level 3, which we feel is too early. QAPI contribution and analysis, we're going to perform the surveys from the QAPI team itself. So we're going to get the surveys from the residents and from the staff, and then we're going to do a survey from the QAPI teams themselves, the ones that are being affected by it. We're going to assess the data and the trends. We're going to analyze for potential survey biasness and variables. We're going to see if there's any reason why we're having so much variability. We're going to make sure that the data has some veracity, is truthful, is reliable. And we're going to assess the cost and the risk versus benefits based on the level of improvement from the change. Because everything costs. We have to make sure that we are in conjunction with the administrator and the finance office about these changes. And we want to ensure that we're going to have short-term and long-term effects. We can't always have long-term effects. People have to see something now. That's why we're talking about incremental improvements towards a major goal. We're going to have some major goals too that we reach. We'll work on them little by little, but we also want to have some short-term effects that they can see right now. And then once that's done, we'll submit the approval to the administrator. And then continuous improvement, we're going to perform resident random sample surveys every 30, 60, 90 days after implementation. There's 96 residents. It's not that hard to do a random sample survey. They have plenty of time to do it. We can even give them extra credit for it because they have credit with the hours, and that goes towards the auction of the month, and that goes towards their canteen. And the canteen is a way for them to get cigarettes, sodas, candy, and that kind of stuff. We also want to perform staff volunteer surveys every 90 days. Staff is pretty busy. We're going to do this every 90 days when it comes to getting the staff surveys. We're going to discuss the effects of the changes in stand-up meetings, which is done every morning, and then also the all-staff meetings every month. Implementation should be small, manageable, building towards a goal. Then after 90 days, implementations go from pilot/draft to policy/protocol if found beneficial after administration and state agency approved. We don't want to just have it squandered as a draft. If it's good, if the data backs it up as something that is a positive change that we want, boom, let's make it a draft. Let's make it a policy and procedures. Move from the draft aspect of it and make it a policy and procedure. Of course, making sure that we are falling in lines with Title 22 and other regulatory issues. So the conclusion of all these changes. We have 2 options as Merced Behavioral Center goes. We either innovate and thrive. We're in a time now where you can see a psychiatrist through a camera on a screen. You don't have to be face-to-face to them. We need to innovate and thrive. We need to move on with the world. Psychiatric nursing has been one of the areas of nursing that always been fearful of change. Been stagnated because any type of change, any type of drastic change for mentally ill people can be daunting, can be drastic, can be scary, can be jarring. We want to make sure that we do this safely, therapeutically, in a way that will show why we're innovating and why we want to thrive. We want to increase our numbers of satisfaction, recidivism rate, and just increase the chances of really successful treatment. So we either innovate and thrive, or we stagnate and jeopardize. And what do I mean by jeopardize? Well, we jeopardize our facility. We jeopardize our relevancy. We want to make sure we don't do that. We don't want to jeopardize why we exist. But that's only one piece of the puzzle. That's only one half of it. It's not just innovate and thrive and stagnate and jeopardize our way of life, our livelihood. But it's also our residents. Remember, we're dealing with young people. They're not to decrease the the importance of the elderly and their treatments. But like I said, we have people in the prime of their lives who are missing out there, who have to be in a locked facility away from their families, away from their loved ones because of bad decisions, because of a bad genetic lottery. We need to show them that they're more than just someone who has to come up for MedPass and take their pills. We want to show that there's more to that than being a resident, a patient. One person I was particular, I can't really recall the name, but it was a person who did TED Talks, and she spoke about her 20-some years in a state hospital, and then she moved on and got a degree and whatnot, and was able to be on the right meds and all that stuff. And now she, well, at the time of the video, she was one of the deans over at UCLA. You can go from being what they would consider a case that's a lost cause to something more, just to having purpose. What purpose they have, what purpose they want, that's entirely up to them. But I want to be there. I want our facility to be there to get them from A to Z. So that's why. That is why we have these copies. That is why we have all these changes, this action plan, this communication plan. We want to make sure that our focus remains those two entities. Our facility, because make no lie, we need jobs. You know, we have mouths to feed, but also because our residents need someone to care for them too. We need someone who's going to tell them, you matter. And thank you. So these are our references. You'll be able to see it on there, and that's it. Thank you.